We know motor control impairments exist across the athletic population, and Phil mentioned a clinical population that we're very used to, and that's total knee replacements. Recognize that patterns of movements change with total knees as well. And what I want you to recognize is there are multiple research studies that demonstrate these impairments exist in a variety of populations. So we really can't go diagnosis specific with our testing recommendations. We want to go broader than that and recognize that almost every patient in the outpatient rehabilitation setting needs functional testing of some sort. Phil and I were asked to complete a chapter on that topic. How do we use screening, testing, and assessment across the rehabilitation continuum from prevention all the way through to rehabilitation? And it was a very challenging chapter to write. We were excited to get that done. And I want to start today with where most of us spend our time, and that's rehabbing the patient. If we jump right into the rehab component, they have pain, so we know we're in the assessment component, and that's where we recommend going to the selective functional movement assessment for our movement piece. We want to start that early on, and we want to run through each of the patterns of the SFMA, working to normalize those as we work in parallel with our traditional rehab. As the patterns improve, we recommend getting down through single leg stance, doing your best to get each of those patterns functional and non-painful. And at that point, it's appropriate to move toward our screening and testing, the one body weight components, the functional movement screen, and the Y-balance test.
So we're at the point in time in our rehabilitation process where we've worked to normalize the basic movement patterns of the top tier tests of the SFMA. So the basic things that anybody needs to do regardless of their activity level, those things are normalized. They can stand on one leg for 10 seconds. Where do we go from there?
At that point, it's important that we document their clinical function with some level of test. We strongly recommend at that point going to the Y-balance test. Again, this is irrespective of medical diagnosis. We functionally work them through things from an assessment perspective. Now we have to measure it. Remember how we got in trouble when we thought our assessment was enough and our professional judgment was good enough. So let's go ahead and measure that. With the Y-balance test, we entered it into the Move to Perform software, which gives us data related to how they do specific to their peers, gender, age, match, which gives them an individual result, which patients love, and depending on how they do, some very clear objective goals to work for from a functional perspective. So no matter what the diagnosis, at a minimum, we're going to have a movement assessment measurement and a Y-balance test measurement.